Good morning, everyone. I am Estibaliz Lazaro, and thank you very much for being here today. So I will talk about chronic histiocytic intervillositis. We'll go through its diagnosis, its implications during pregnancy, and the current strategies for management. Here we go. Here is the outline of my presentation. So first I will explain why I chose this topic. This topic lies at the crossroads of internal medicine and obstetrics. We are used to manage patients with chronic diseases during pregnancy, and very often we also have to manage patients with adverse obstetric outcomes and unknown etiologies. In these cases, it can be a diagnosis of CHI. CHI is one of the possible causes of fetal loss, which is unfortunately quite common during pregnancy, with early spontaneous miscarriages around 12% of the pregnancies. It is a poorly understood condition. In cases of fetal loss, maternal factors are involved in about 30% of cases. Fetal factors explain around 25%, and placental factors account for only about 5%. But in nearly 30% of cases, no clear cause is identified, as some of them could also be due to placental inflammation and CHI. So let's talk now about CHI. CHI is part of a group of rare placental inflammatory diseases. This group also includes velitis of unknown etiology and massive perivillous fibrin deposition. These conditions share similar consequences. They disrupt normal placental function. As a result, they can lead to miscarriages, intrauterine growth restriction, and intrauterine fetal death. When facing adverse pregnancy outcomes, an etiological workup is essential to identify the causes. We must rule out any bacterial, viral as COVID, or parasitic infection as Plasmodium that could lead to placental inflammation. Autoimmunity can also be associated as connectivitis or antiphospholipid antibodies. One of the most concerning aspects of placental inflammatory diseases is high risk of recurrence. In women who have had one affected pregnancy, the likelihood of recurrence in future pregnancy can reach up to 80 to 100%. This makes early recognition and close monitoring of this disease absolutely essential. CHI is defined by a dense inflammatory infiltrate in the intervillous space of the placenta. About 80% of these cells are macrophages, and the remaining 20% are T lymphocytes. The condition is also marked by trophoblast and fibrinoid necrosis. On immunohistochemistry, CD45 positive and CD68 cells confirm the presence of monocytes and macrophages in the intervillous space. CHI is rarely diagnosed because it requires a systematic histological analysis of the placenta. Its estimated prevalence is below 1%. CHI is classified according to 3 grades based on the extent of the intervillous space infiltrated by immune cells. Below 10%, it will be the grade 1. The grade 2 represent the CHI when the infiltration affects between 10 to 50%. And finally, the grade 3 is when the intervillous inflammation exceeds 50% of the space. Patients with CHI often present certain clinical characteristics. Tobacco use is observed in about 12 to 30% of cases, which may contribute to placental inflammation. The average age of affected patients is typically between 32 and 34 years old. BMI is usually in the range of 22 to 26, and around 40% of the patients have a history of autoimmune diseases, which may predispose them to immune-mediated complications like CHI. The obstetrical outcomes in cases of this disease is generally poor, as shown by this recent systematic review. CHI is associated with a live birth rate around 50%. The fetal loss rate is important. Before 22 weeks of gestation, it is around 20%, but after 22 weeks, the rate increases to 25%. IUGR rate affects about 45% of pregnancy, and the recurrence rate for CHI is significant, with approximately 30% of women experiencing it in subsequent pregnancies. Additionally, nearly 50% of patients have a history of fetal loss prior to the diagnosis of CHI, particularly miscarriages before 14 weeks of gestation. As I said before, the obstetrical outcome in CHI is closely correlated with the degree of macrophagic infiltration in the placenta. We have shown that as the grade of infiltration increases, as you can see here, the fetal survival rate decreases. One important thing is to find a biological predictive marker, because the only way to diagnose a CHI is to make a placental analysis. But currently, there is no accepted biological predictive marker for this disease. One of these could be alkaline phosphatase levels, but it is not specific at all to reliably predict the condition, the presence of this disease. In this paper, you can see that alkaline phosphatase levels are elevated in CHI, but also in other diseases that share similar profiles with CHI. So, according to this data, we cannot say that phosphatase alkaline levels are good biological predictive markers in CHI. So despite the serious impact of CHI on pregnancy outcomes, therapeutic strategies remained largely ineffective. We have different virus molecules we are used to give to patients with pregnancy and inflammatory disease, but all of them have been tested and the results are not good at all, as aspirin, heparin, hydroxychloroquine, immunosuppressive treatments, steroids, or immunoglobulins intravenous. Similar, in this meta-analysis, investigated the impact of several associations as aspirin and heparin, or aspirin, heparin, and hydroxychloroquine on the live birth rate in patients with a story of CHI. As you can see here, the results were not particularly promising. None of these treatments demonstrated a significant improvement in the live birth rate. While individual treatments have not shown strong efficacy, Arsène Mekinian showed us a few years ago that combining different therapeutic agents might offer some benefits in these patients, with a chance of achieving a live birth in patients with CHI. Recently, Chloe Bradis demonstrated that the combination of aspirin, heparin, hydroxychloroquine, and prednisolone significantly increases the chance of having a live-born baby. You can see here the data of the patients treated with these combined molecules, and you can see that we have a better chance to have a live-born baby, including all pregnancy years or including only full-term births in this slide. So, in practice, how should we manage a patient with a diagnosis of CHI? First, you have to confirm the pathological diagnosis, and it has to be performed by a fetopathologist with expertise in this disease. It is very, very important because most of the time the data when we analyze the placenta show that it is not really CHI, it's just another inflammatory disease. When you are sure that it is this disease, you have to perform an etiological workup, which is very necessary to rule out infections and autoimmune conditions that might contribute to placental inflammation. Once diagnosed, the treatment strategy should be tailored according to the patient's obstetrical history, and then you can propose a combination of different molecules as aspirin, heparin, hydroxychloroquine, or prednisolone. And in case of recurrency, despite this combined treatment, then we have some limited data suggesting the use of intravenous immunoglobulins, tacrolimus, or anti-TNF therapy. Let's talk now about the pathophysiology of this disease, because we have very recent data showing that maybe we could treat these patients differently. We have two different mechanisms which are being involved in recent studies to explain the inflammatory presentation of this disease. The first one could be that CHI is a consequence of alloimmunisation, where the maternal immune system becomes sensitized to fetal antigens inherited from the father. This can lead to the presence of high levels of fetal antibodies targeting paternal antigens in the maternal circulation. These antibodies may trigger an immune response that causes inflammation and damage to the placenta. And as you can see here, complement activation has been observed in CHI lesions, contributing to the inflammatory cascade and placental dysfunction due to alloimmunization. The gene expression patterns observed in affected placentas suggest this immune response that is consistent with alloimmune-mediated damage, further reinforcing the idea that CHI may be driven by maternal response to paternal antigens. Transcriptomic analysis suggests a strong interference signature with the hallmark of allograft rejection, as you can see here. So combined together, all of this data could suggest two promising avenues of treatment targeting the FC receptor neonatal, the FcRn, or targeting the complement system. The FcRn, as you may know, is responsible for the recycling of IgG antibodies, including those that may be involved in alloimmunization. So by targeting the FcRn, we could potentially reduce the persistence of maternal antibodies against fetal antigens, which could help reduce the inflammatory response in the placenta. This approach could offer a way to limit the alloimmune response and prevent placental damage in CHI. On the other hand, by targeting the complement system, we could significantly decrease the tissue damage in CHI lesions. Our recent research in Bordeaux has suggested that CHI could be a consequence of NLRP3 inflammasome activation. The NLRP3 inflammasome is a key component of the innate immune system, responsible for triggering the release of pro-inflammatory cytokines as IL-1 beta. In the context of CHI, there is evidence of placentas affected of upregulation of inflammasome gene transcripts, as you can see here, compared to control samples. This activation leads to increased inflammation within the placenta, contributing to tissue damage and the characteristics features of CHI, such as trophoblast necrosis and macrophage infiltration. According to this data, we have shown that there is a strong inflammasome signature in the affected placentas and an inflammasome-related cytokines, particularly IL-1 beta signature and IL-18 signature in CHI. Interestingly, when we use colchicine and anakinra, which are known for their ability to inhibit inflammasome activation, placental inflammation is controlled, as suggested in these three patients treated with this strategy. They had a good obstetrical outcome with the controlled inflammasome activation, as suggested here by NLRP3 and Pr staining, without treatment before the colchicine and anakinra combination, and then after with this treatment when they had a favorable obstetrical outcome without any recurrence of CHI. So to conclude, here are my take-home messages. First, placental immunology is at the heart of CHI, and understanding the immune system involved is crucial for developing innovative therapeutic perspectives. Second, CHI is a rare disease with a severe obstetrical prognosis, and it carries a significant risk of recurrence. Early diagnosis and intervention are critical for improving outcomes of these patients. Placental anatomopathology plays an essential role, particularly in cases of unexplained recurrent obstetrical events. It is vital to perform histological analysis to accurately diagnose and manage CHI. There is a need for active research in this field to further unravel the pathophysiology of CHI and explore more effective treatments. I would like to thank the different teams who helped me for this study, especially the obstetrical team, particularly Loïc Saint-Tirse and Aurélia Mathusi, the Immunoconcept Lab, especially Patrick Blanco and Fanny Silvestre, and especially all the patients who actively participated in the different studies. Thanks a lot.